Hello, everybody. So this particular video is on some markers we see in autoimmune diseases, as per the request of one of our fellow subscribers. So there are three tests I will discuss. One is ANA, second is ferritin, and third is CPK. Huh? There are many autoimmune markers, right? You can have SCL70, rheumatoid factor, and all, but those are not so much relevant. ANA is relevant. Huh? So just these three I will discuss briefly. Is the salient points. So first I'll start with ANA. So ANA, antinuclear antibody, and if you get a ANA positive in any patient in the ICU, does it mean that the patient has disease? You think he will have disease if the ANA is positive? That is not true. So first of all, ANA can be found in a normal person. In the cross section of the population, ANA is found in 5 to 10% of the patients, and in the elderly up to 20%, first of all. So that should be clear. Then ANA has many false positives. Apart from being present in the normal population, it can be due to drugs, it can be due to HIV, it can be due to infections, so malignancies. So ANA can be positive in all these conditions. So this is one set where ANA can be false positive and does not mean autoimmune disease. All right. Then how is the ANA done? That is also very important. There are two ways of doing ANA. One is the IFA, that is immunofluorescence assay. And the second is the ELISA. So IFA is much better and much reliable. And if in doubt ever, please get the ANA repeated. There's a lot of problem with the ANA, especially with the lower labs. Now, if ANA is coming positive, then what is the most likely disease if the patient is sick? The most likely disease is lupus, SLE. In a patient who's having symptoms suggestive of SLE is in the ICU, because SLE can be devastating. All kinds of organ failures occur. You must have seen SLE can be very bad. So if you think the patient has SLE, ANA cannot be negative. One ANA can be negative because of some reason. You send it again, that should be negative, positive. You cannot diagnose active SLE with a negative ANA. If sometimes SLE goes into remission, at that time you can have ANA negative. But if the patient is in the ICU because of SLE, that means the disease is flared up. ANA has to be positive. All right. So, and the other thing is about the titers. So I mentioned IFA. So the titers are like 1:20, 1:40, 1:80, 1:60, 160. So titers should generally be more than 180. That is also another thing, because low titers take away from the specificity of the test. Now, the other conditions in which NA is positive is mixed connective tissue disease, which is a autoimmune disease in which it has 100% of the time it has to be positive, and then drug-induced lupus. Lupus can be because of certain drugs also. There also you have 100% positivity for ANA. So then there are a lot of other conditions, right? Immunological rheumatoid arthritis, scleroderma, Sjogren's syndrome, vasculitis. So here it varies. The positivity of NA varies from 50 to 88, 90%. So it can be negative here in these conditions. And we are not discussing this because then it is very complicated. You have to look at the clinical feature, the other tests, and all that. Immunology goes into rheumatology actually. Then apart from this, ANA cannot be used to follow the patient, the course, the prognosis, etc. It is mainly a diagnostic test, and do not send a arbitrary ANA. ANA will just send it, because unless there are clinical signs and symptoms suggestive of a disease, that is mainly SLE or any other autoimmune disease, do not send ANA because it will lead to confusion only. Right? There should be a pre-test probability, right? So that is, about ANA. Its main role is in SLE. You cannot have SLE patient in the ICU if the ANA is negative, and there are many false positivity causes for ANA. So that is ANA. Which move on to ferritin. So why ferritin? I hope you people have some idea about ferritin. So ferritin to an intensivist is important because of HLH. HLH is being recognized more and more, and now we have the dengue season going on, and dengue can cause HLH. A lot of viral infection can cause, malignancies can cause HLH. It can be primary HLH. So what is ferritin first of all? So first of all, ferritin is a molecule in which there is protein, and protein is bound to iron. So it's a storage kind of a molecule, and it is mainly in the liver. Ferritin stores iron in the liver in the form of complexes with proteins. However, it is present in other tissues also, and HLH is a highly inflammatory state, right? It is a very inflammatory state, and when there's so much inflammation, ferritin gets released from the immune cells and from other tissues. So in HLH, ferritin goes beyond 10,000 generally. Okay, it can go up to 20, 30, 40,000 also. So if you're suspecting HLH, make sure you send the ferritin. So there is a diagnostic criteria that is fair enough, but you cannot have a ferritin, less than at least 5,000 for HLH. Normally it is more than 10,000. But also remember that there are other conditions which can cause ferritin more than 10,000. So one has to have a clinical suspicion and clinical judgment for the diagnosis of HLH, also considering all the features. And one has to differentiate from the other diseases. And these, first of all, is sepsis. In sepsis, you can get ferritin more than 10,000. So how will you differentiate clinically sepsis from HLH? So first of all, fever will always be present in HLH, while it may or may not be there in sepsis. Secondly, cell counts are always decreased in HLH, while in sepsis, TLC may be increased. Right? Then third, you can get hepatosplenomegaly in HLH, while it is very rare in sepsis. Fourth, you get a erythematous rash in HLH, while in sepsis, rash is generally due to thrombocytopenia or bleeding. And fifth, hyponatremia does not occur in sepsis. You can get it in HLH because there is SIDH in HLH. HLH affects all the organs, while sepsis still does not affect all the organs. You don't get SIDH in sepsis. So the other conditions in which ferritin can go beyond 10,000 is adult Still's disease. Adult Still's disease is autoimmune disease, and other autoimmune diseases, then certain malignancies, and so on and so forth. There are other conditions. But if you are getting more than 10,000, make sure there is no HLH and there is no sepsis. You have to differentiate from sepsis. These two conditions are very important. Then apart from this, ferritin can be increased in any patient who has iron overload. There can be hemochromatosis, which is a primary iron disorder, or patients like thalassemia and all who are dependent on transfusions for their life can have iron overload. Here, ferritin will go high. Commonly, actually, to the physician, ferritin is used to diagnose iron deficiency anemia because, like I told you, it has iron in it. So, if there's iron deficiency anemia, ferritin levels go down. In males, it will be less than 30. In females, it will be less than 15, 30 and 15. So that is diagnostic of iron deficiency anemia. However, in the ICU, you cannot use it to diagnose iron deficiency anemia because there's intense inflammation and it is acute phase reactant. So its levels go up. Diagnosing iron deficiency anemia in the ICU is not so easy. It's pretty difficult because all these factors, which indices which tell us about iron deficiency, they get altered in the ICU. Now, what are the normal values for ferritin? So the normal values for ferritin are less than 200 for females and less than 500 for males. So that is about ferritin. There is nothing more than this. Because of increased prevalence and recognition of HLH and it being such a devastating condition, I thought ferritin, a word about ferritin would be important, and it was also requested for by one of our colleagues. Now, lastly, a word about CPK. So, creatine phosphokinase or creatine kinase, exists in three forms. It is either MM form or MB form or BB form. BB is brain, MM is muscle, and MB is heart. So mainly we do now CPK and we do it for the muscles. So very important point I want to tell you is if in any patient, we don't do CPK routinely, but we do SGOT and SGPT. If SGOT is disproportionately high compared to SGPT, always do CPK. Why? Because SGPT comes only from the liver, while SGOT comes from the liver, but also from the muscles and also from the heart. Heart does not, really contribute to it so much. But if the SGOT is very high and SGPT is not so high, always do a CPK because the SGOT may be coming from muscle damage. Just a clinical clue I want to give to you. The second clinical clue I want to give to you, and from my experience, is if there is hyperkalemia unexplained, again do CPK because rhabdomyolysis was hyperkalemia. Two important clues about CPK. Now, why CPK becomes high? That is rhabdomyolysis. There are n number of causes of rhabdomyolysis. That is, you can open the book. But a very important condition in the ICU is viral myositis. Sometimes these patients come with a lot of pain in the muscle and body paralysis and muscle, they jump, you just press the muscle, they will jump. Once in a while they come. And CPK will be 50,000, 1 lakh, 1,50,000. So these are patients of viral myositis, and you have to give them steroids and manage the rhabdomyolysis. So CPK is important again because if you're thinking the patient in the ICU has an active muscle disease, CPK cannot be normal. All right, normal values are less than around 200. And any condition which is seriously affecting the muscle will have a CPK more than 5,000. Minor rises like 1,000 and all really don't mean much. Patient is having rhabdomyolysis because of immobilization, but intramuscular injections, one seizure, they all can make a marginal increase in CPK. So those were, I think, all the points I could enumerate and think of. The final point is, myoglobin is coming up in a big way in rhabdomyolysis. And I think more and more labs will start doing it, and it will replace CPK in rhabdomyolysis management. It has many advantages. It rises faster, and it correlates much better with the damage that is happening, myoglobin levels. So, okay, guys, that's all from my side. Any questions, any comments, please put them there. And the other thing is, we now have 200 videos in our channel. And if you guys are finding any difficulty navigating and all, please let me know. And there have been a lot of questions asking for, asking generally what is what, that why this is happening, why that is happening, can you make a video? So we have 200 videos there, and a lot of answers are there already in the videos. You guys have to trace the videos. So how do you trace the videos? So if you search for the video in your laptop and desktop, then only you can search for it. Otherwise, if you get the search function is not there in the mobile phone for a particular video. You can search for a playlist in either the laptop, desktop, or the mobile phone. But you cannot search for the video in your mobile. It's not there. The function is not there. So you can go to the playlist and then look for it, or in a desktop, laptop, type the name of the video you want. Supposing you want acidosis, you just type acidosis in your laptop or desktop, you will get the video. It's happening frequently. You guys are asking, oh, sir, what is this video? We need this video, that video, some questions. They're all there. 200 videos, a lot of videos. 200 videos, okay. Okay, so in case you're still having problems, I'll try to organize the playlist better. I think that's all we can do. Okay, so bye-bye, guys. Take care. Thank you for your love, support, and continued. Uh, and also, 27th, we have the virtual global conference on fluids. So do join us. It will be live on Zoom. It will be live on YouTube. To join, click on the flyer, the icon, register, and you can join either on Zoom or YouTube. Take care. Good night. Goodbye.